Bismillahirrahmanirrahim. My talk is basically based upon cases. I'm not going to show you a lot of data. Uh, as we all know that primary PCI is an established form of treatment for acute myocardial infarction, and it has shown to have better outcomes as compared with thrombolysis. Although performed when patient is critically ill, generally primary PCI is technically not very challenging. However, one may face unusual situations or complications which may require advanced technical skills, expertise, and instant decision making. I'll present a few cases. The first case is a 65-year-old male, a known case of hypertension, presented with chest pain. ECG revealed acute anterolateral myocardial infarction, and there was no contraindication to primary PCI. And this is what he turned out to have. You can see that there is a critical distal left main stem disease, and that's the disease always extended the proximal LAD. There's a disease in the proximal LAD also. And patient had a normal right coronary artery. The patient had ongoing chest pain and had a TB3 flow. He was offered bypass surgery on the table that we can arrange surgery, but he declined and we had to proceed to primary PCI. Now, how do we proceed with this? I mean, this is an emergent situation, and there is the ostium of the circumflex looks almost healthy, so we decided to go for a crossover approach from left main into LAD. It was pre-dilated with 3.5 balloon and then stented with 3.538 stent, and then post-dilated with the 4O balloon, and that was the final result. So crossover stenting from left main to LAD is generally technically not very challenging, and decision of crossover stenting is easy when circumflex is non-dominant or a small side vessel with a healthy looking ostium. And such a technique provides a quick fix in an unstable situations where CABG has been declined. Now the second case is a 39-year-old male who presented with chest pain for 7 hours. He showed an acute inferior myocardial infarction. He was planned for primary PCI. As you can see, the left side injection shows somewhat ectatic coronary arteries, and as we took the picture of the right, it was all full of thrombus. And we could see that it was ectatic and it also had an early bifurcation. Now in this situation, although thrombus aspiration is not a class A indication, but we did multiple runs of thrombus aspiration, and we were able to restore the flow into this largely ectatic coronary artery with a lot of thrombus. We decided to keep the patient on tirofiban, and we deferred further treatment so that we can have a look at the patient again. He's also kept on dual antiplatelet as well as rivaroxaban 2.5 milligram twice a day, and the patient's angiogram was done after 1 week. It showed the same result, but then it was again repeated after 4 weeks of further treatment, and you can see that most of the thrombus has dissipated after 4 weeks, and the patient had much better and improved blood flow. And we did not stent this patient, and we left him on medical treatment. So stenting of an ectatic and thrombus-laden vessel is associated with higher rate of stent thrombosis and is preferably avoided or deferred. Thrombus is still useful in lesions with very, very heavy thrombus burden. Now, third case is a 59-year-old male with history of primary PCI to LAD, presented with chest pain of 6-hour duration. ECG showed acute anterior MI with likely diagnosis of late stent thrombosis. And as you can see, you can have a stent in the mid LAD, and that is totally thrombosed. And then it was wired, and but something has happened here. Can anybody guess what has happened here? Anyway, if you have a closer look, you can see there is a dissection of the proximal LAD because the guide cath has inadvertently moved forwards. So this strategy had to be changed, and LAD, the second stent had to be placed starting from the ostium. So you can have a change in the strategy. Instead of having a treatment of stent thrombosis, you had to treat the dissection of the LAD also. So we put in a longer stent and then covered this dissection very well. So one should be very watchful during the procedure, and Be aware of these complications. Change of standing plan may be required instantly. The one should have to pay attention to the meticulous handling of these guide catheters to avoid guide catheter related complications. This is the next case. This is a 69-year-old diabetic male presented with typical chest pain for 6 hours, and ECG revealed acute posterior wall MI. Here you can see there is a discrete lesion in the circumflex, in the obtuse marginal branch of the circumflex, and it looked like a simple and straightforward stenting case. And here you can see it's in balloon, and then a 3.3 into 19 stent has been deployed. But then we see what has happened at the ostium of the circumflex. I think one of our junior colleagues were doing this procedure, and he pulled the stent balloon back without having it completely deflated. So you has to give time for the stent balloon gets deflated. He pulled it, that pulled the guide gates into the left ostium of the circumflex and produced this. So he went into chest pain, he had a VTVF, he had a CPR, and was luckily revived, after 15 minutes of CPR. Now what to do now? So we decided to stent from the left main into the circumflex as a provisional technique. So this was 3.519 stent deployed from the left main into the circumflex. And then we had to open the ostium of the LAD, and we finish off with kissing, and that was the final result. We had a pot on the left main also. So that was the final result. So you have to pay again, it's critical to avoid forward movement of the guide cath once you are pulling the balloons or the stents back. Completely deflated balloon when pulled back is less likely to cause forward movement of the guide cath. Haste makes waste. Now this next case is a 43-year-old male. He presented with acute chest pain for 5 hours. On examination, he was sweaty, unwell, with the blood pressure of 85/60, pulse was 120 per minute. Obviously, he was in cardiogenic shock. You can see there is an ST elevation lead, which is greater in lead 2 than in lead 3, and there was elevation in the V5 and V6 also. And our guess was the problem is in the circumflex. And there we took a left side guider and opened up the circumflex. There's a large obtuse marginal branch. You can also see that LAD is not only disease, it's diffusely disease, and late filling, and you can also see cross filling of the right coronary artery. So as we suggested by ECG, we just proceeded to the angioplasty of the circumflex, and we did not, we just stopped after doing angioplasty circumflex. This was the procedure. And as you can see, the right was totally occluded. It had bleeding collateral. Had we, thought of doing the right, it would have taken a very long time. So in cardiac shock, you have to identify the culprit lesion. Just do that as per the shock trial and come out. And then later on we sent this patient for bypass surgery because he had a disease in LAD and RCA. So I have already said that. Case number 6 is a 72-year-old male, diabetic, hypertensive, post-cabbage, and since 2007 presented with chest pain and nausea 4 hours. He had history of inferior MI and PCI to vein graft to RCA was done in 2019. His current ECG again revealed acute inferior MI. This is his native circulation. Like you can say, there's nothing left there to intervene, at least in an acute setting. His right coronary artery is occluded, and this is a vein graft to the obtuse marginal, which shows a lot of thrombus burden and almost a total occlusion, but still looks like a fresh case and a culprit lesion. And his lima was okay. And we also know that the vein graft of that RCA was completely occluded. We normally PCI, primary PCI vein grafts is riddled with complications, and it's not done with great enthusiasm. Anyway, in this particular patient, we were able to have a very good result. So if we are faced with the last graft and it looks like a fresh case, you can attempt and get a good result. Next case is the case, 6-year-old lady presented with chest pain for 6 hours. ECG revealed acute anterior wall MI, angiogram showed calcific and tortuous LAD and circumflex, and a focal lesion in the mid LAD. You can see there's a lot of calcium in the circumflex, a lot of tortuosity and a lot of calcium. But the lesion in the mid LAD is quite focal, and it looked like that we can get away with this lesion in about say half an hour, 20 minutes. But we able to cross the wire, but then the balloon won't cross. We cross the balloon, then there was a dissection and no reflow. And then we have to give intracorneal adenosine. We try to stent the lesion initially with a 2.25, 2.75 14 stent, but that couldn't cross. We took a smaller stent, 2.25 24, still couldn't cross. And during this maneuver, we were able to balloon once again. The flow was restored, but there was a we end up having a dissection in the left main stem. This is the we try to change the wire to a support wire on the microcatheter, and we took a guide liner also, but that again did not succeed, and we end up having a dissection in the left main stem, which we had to stent with the 3.518 stent. We had to wire the circumflex also. So we dilated with 4.5, but this is the end result. We had some fluid in the LAD and we decided to accept this. Patient made uneventful recovery and remained stable later on medical treatment. Apparently simple case can end up with multiple complications, and one should hoping for the best, but one must be willing to accept our failures and be prepared with the worst. I can just one more case, last case. So this is a 40-year-old male presented with chest pain for 3 hours. EC showed acute inferior wall MI with reciprocal changes in 1 and AVL, as you can see here. And that was his left system. You can see there is a disease in the LAD and the diagonal, but the flow is TIMI3. So we went for the right coronary artery, and we can see there is an occlusion in the distal right coronary artery. We did the primary PCI to the right, and we obtained a good result. As you can see, although we had a very good result in the right coronary artery, the patient continued to have chest pain. This is quite unusual. As soon as we open the artery, the patient generally have settlement of chest pain. So we again repeated the ECG on the table, and this is what we saw, that we can have last ECG showed that acute inferior MI, but now we have a lot of changes in the anterior leads. ST segment 4 meter down in the anterior leads, showing that the problem in the LAD and diagonal had got worsened. So we went back and we fixed the diagonal and the LAD, and we were able to achieve a good result. That was the result after the angioplasty. So take home message that in general we still prefer the culprit or single vessel PCI in primary setting. However, clinical situations may dictate otherwise, and multi-vessel PCI may have to be necessary. I'll just go to the last slide now. I have a couple of interesting cases, but I think we just in interest of time. Primary PCI is not a walk in the park. In fact, a high degree of skill and expertise is required. Complications can occur when patient is already critical ill. Change in strategy may become necessary. Meticulous technique can help avoid iatrogenic complications. One should not hesitate to get help from the experienced colleagues. Thank you very much.